Hi, I'm Dr. Dennis Kong of Eye Specialist Center, Kuching. I will be talking on my early experience with Rayner EMV lenses today. This talk has been sponsored by Rayner and Mandarin Optometric. EMV is a non-diffractive IOL with monofocal levels of contrast sensitivity, dysphotopsia, and high levels of patient satisfaction. It has been designed by Professor Graham Barrett in collaboration with Rayner. Basically, this lens is designed to utilize the positive spherical aberration and extend the depth of focus by about 1.5 diopters as shown in the diagram. Clinical results of EMV lens also show about 70% of spectacle independence for distance, intermediate, and near vision. There was also no problems with depth perception, contrast sensitivity issues reported, and there was no problems with dysphotopsia and glare and halos issues. Studies by Dr. Royal also showed that the EMV lens outperformed the Technics Eyehance in the defocus curve, especially at the important area of about -3 to -2 diopters. EMV patients also reported spectacle independence in the distance and intermediate vision 100%, and about 33% of them has near functional vision. In a prospective case series in comparison with VVT, Symphony, Eyehance, and Technics lenses, the EMV lenses demonstrated excellent visual outcomes for distance and intermediate vision, and also good visual acuity for near vision. The EMV lens is made from hydrophilic acrylic material and is glistening free, and the square edge design results in a very low capsulotomy rates, and also the lens is very stable in the back post-operatively. The EMV lens comes preloaded, and in comparison with other preloaded IOLs like Acrisoft, Clarion, and Technics, it has a very low PCO rate and no glistening, and also the centration is excellent post-operatively. The reddish band is an indication of the depth of focus of the lens, and as can be shown in the last line, when the second eye is offset by about 1 diopter, the range of vision is improved, especially the near vision. Suggested guidelines for EMV lens implantation are target plano for the dominant eye and -1 for the second eye. Ideally, for cases with astigmatism of 1 diopter or less, it is a very versatile lens, and it is ideal for mono vision strategy and great for the second eye. It is very cost effective and perform well. Some real-world cases. This is a 65-year-old man who had LASIK and then bilateral EMV lens. The right eye post-operation 1 month refraction was about just over -1 diopter, and the unaided distance visual acuity was 20/40, and the unaided near visual acuity was N4. The left eye post-operation 1 month was about -0.75 refraction, and the unaided distance visual acuity was 20/25, and the unaided near visual acuity was about N10. He does not need glasses and have no problems driving at night. The second case is a 66-year-old male who had bilateral EMV lens. The right eye post-operation 1 month was about minus 0.35 diopters, and the unaided distance visual acuity was 20/25, and the unaided near visual acuity was about N8. The left eye post-operation 1 month was about minus 1.25 sphere, and the unaided distance visual acuity was 20/30, and the unaided near visual acuity was N5. He does not need glasses. The third case is a 74-year-old female, a mix and match case with right enVista monofocal and a left EMV lens. The right eye post-op refraction 1 month was about minus 0.25, and the unaided distance visual acuity was 20/25. The left eye post-op operation 1 month was about minus 1.25, and the unaided distance visual acuity was 20/70, and the unaided near visual acuity was N6. The Rayner EMV lens comes preloaded, and 3 simple steps for injection. Injection of the OVD to fill the chamber of the cartridge, closing the flaps, and then slow control injection of the lens. Injection of the OVD into the cartridge and visualizing the OVD web filling the chamber. The flaps are then closed with a click and confirm that both sides are firmly locked. The cartridge is then inserted into the anterior chamber, and the lens is injected in a very controlled and slow fashion. It is important, like any other delivery system that involve injection, to inject the lens slowly. The lens is then down into the back properly with the Sinskey hook, and then centralize. OVD is then thoroughly removed from the anterior chamber in front of the lens. The Synco INA is then maneuvered behind the lens, and then viscoelastic thoroughly removed from behind the lens as well. Finally, a well-centered lens in the back, and it is important to remove all the viscoelastic so that the eye is quiet and there is no IOP issues post-operatively. Since at least 30% of surgeons practice monovision strategy, EMV lens with the additional depth of focus of about 1.5 diopter is a great tool for the surgeon to enhance the monovision strategy, especially for the second eye. In addition, it is comparatively much more affordable for the patient as well. Thank you very much.